and CK for the cheek. NL is for the nasolabial fold, the lips LP, the Marriott line, okay, it's coded by M, and C is for the chin, and GW is for the jaw. So this is the face. Whenever we want to put filler in the face, we have either to be superficial or deep. So there are points that you are mandatory to be deep, and these are coded in blue. Others will be coded in red, because it's better to be superficial at this area in order to get better results. And there are some dangerous structures that you might end up with complications if you go a little bit deep with your filler. So the first is the frontal spots. You can see that this is F1, F2, and this is F3. And when you inject the filler, you have to be more or less superficial. The thing about that is that you want to break down the fibrosis between the bone and the skin at this area. So you have to be gentle, you have to be superficial while injecting here. And why you have to be superficial, especially at F1 and F2, because this is the course of the supratrochlear and supraorbital nerve, supraorbital nerve and artery as well. So if you increase the pressure around this area, this might cause some vascular events in the eye that might be really harmful. So this is the T1, T2, temple 1 and temple 2. The temple 1 is at the orbital rim, just above the eyebrow by by 1 or 2 millimeters. This is a very important area. We injected in order to get better facelift. And all the techniques that we will be discussing, T1 and T2, are almost always injected. E1, E2, and E3, the eyebrow. So the eyebrow is also injected with filler, mainly Volbella. I like to use a little bit soft filler, around 50 milligram of hyaluronic acid per ml. I don't use really thick filler at this area. We will be discussing this shortly. And usually we inject the eyebrow at the subcutaneous area. Okay, the thing about that is that you need to elevate a little bit the eyebrow from its original position to a higher level up. It helps a lot in escaping the patient, sometimes a blepharoplasty or a direct brow lift. Glabellar area is rarely injected with filler, but usually I do it in males, especially those that are very resistant to Botox. Sometimes the itch is always there. It's not. It doesn't go. So sometimes you have to inject with a very soft, also filler, and you have to be superficial. This area is dangerous, as we have said. An increase in the pressure, interstitial pressure at this area, might cause a central retinal artery occlusion or a central retinal vein, especially if the filler was injected inadvertently in the artery, supraorbital or supratrochlear artery. So you have to be very cautious when injecting the filler at this area. Orbicularis is a very, we have the O1, O2, and O3, rarely also injected with filler. Usually Botox helps a lot in getting rid of the wrinkles, the crow's feet. However, sometimes we inject this area in order to break down the adhesions, the long-term adhesions. And sometimes I use Plexer which is a form of, it's a plasma exeresis. It helps really flattens up those static wrinkles rather than using filler. The tear trough, T1, this is T1, T2, and T3. So the tear trough, usually we start always with T1. Whenever you want to start filling that area, start with T1, and then you go with T2, and always try to spare T3, or you just inject a very small amount there, because this area is really, it ends up with edema if you really fill it a lot. And this might impede the lymphatic drainage, which goes to the submandibular area. So you have to be really cautious when injecting filler at this area. So, and then you have the cheek. The cheek is the most important part, where you have always to start with when doing filler for your patient. For example, I do always cheek CK1, this area here, and you have to be really deep up to the periosteum, and you give a very good bolus of viscid, highly viscid filler, usually Voluma. I use Voluma. I put around 0.2 or 0.3 in each point, 0.2 or 0.3 ml. So in CK1 I put 0.2 or 0.3, CK2 as well, 0.2, 0.3, and CK4. Now in CK3 and CK5, I'm usually more superficial, and that's because I don't want to harm the nerve structures and the artery at the in the infraorbital foramen, emerging from the infraorbital foramen, and CK5 is actually the course of the facial artery. So you have to be more or less superficial. Always when you want to do a lift, you have to inject CK1, CK2, and CK4, as well as T1 and T2. So this is the facelift. These are the most important corners of the facelift, along with the jaw. We will discuss now the jaw in a moment. This is the nasolabial fold in 1, in 2, and 3. Nasolabial fold, rarely injected unless you have a very deep sulcus. We usually spare nowadays the nasolabial fold, and we depend more on filling up the cheeks. And that's because if we are adding more filler at the nasolabial fold, this will make the corner of the mouth very heavy. So in order to make a beautiful lift, it's better to inject always the cheeks rather than injecting the nasolabial fold, in order to get rid of that fold. Mariette line, the lips, we will discuss them in a moment in details. And you have then the Mariette line, okay, and the jaw. The chin, we have the most important parts of the chin are the C1 and C2. If you need a broader, let's say, youthful more look in females, you can do the C5, and in males I usually do the C6. This area here, it gives a more broader chin, especially when combined with mandibular fat emulsification. For example, if you use Belkyra or any other agent that will get rid of the double chin, this will give you a more youthful and beautiful face. The jaws, the most important part, I hope I can just move this here. Okay, great. So we have the jaw 1, which is the angle of the jaw. This is a very important point. You have to be very deep to the bone, and you really need to inject between 0.5 and 0.6 mLs. at this region in order to get the nice acute angle, or let's say the straight angle of the jaw. And then you can go to the ramus of the jaw and inject there as well, and you have to be really deep. JW also, you have to be more or less superficial, because this is the area of the facial artery. This is where the facial artery emerge. So better to be superficial at this area if you want just to enhance it. And usually I use a cannula. I don't use a needle unless I am in really deep structures. For example, J1, CK1, CK2, and CK4, JW2. And then you can also enhance the jaw by doing the JW4 and JW5. Just a quick overview of the lips. The lips is divided into 8 corners. For example, people, they come complaining of smoker's line. So this is the most common usually complaint, and they always bring the attention of the doctor to them. They want you to get rid of them, but whenever you want to approach the lip, you have to be systemic. Okay, first of all, try to fill up the vermilion of the lip. Okay, the body of the lip, the vermilion. Okay, so we always inject LP1, LP2. After that, you start contouring the lip. And what's the meaning of contouring the lip? First of all, you need to contour the Cupid's bow. This is Cupid's bow. Cupid's bow, we have the, usually we have to go with a fine needle, usually 30 gauge needle, and you inject at LP2. Always, I always teach my students, whenever you are injecting the upper lip, you have to be from, you have to inject medial, and then you go with your needle lateral, and then you start injecting as you withdraw your needle. Why is that? Because you really need to make as less material as possible in the lateral part and more at the medial part. So we have the we have 2 frenulum. At the apex of that frenulum, you need to have an acute angle. This is very important to be contoured. And you have the medial and 2 lateral trabeculae, or let's say tubercles. These need also to be contoured as well. These are termed LP4, LP5, and we have the angle, the commissure of the lip. This is LP6. Usually, injection of LP6 is not that important, but unless you do a very good injection at the lower vermilion of the lower lip, you'll start to have this beautiful, nice commissure being angled upwards. But if you feel that the commissure needs to be a little bit elevated, then you do the LP6. So after all, after doing the most important parts of the lip, you can go and do the frenulum. This is the small straight line from the nose to the border of the vermilion, and it's little bit. It's not straight, it's a little bit lateralized. So when you are injecting, you enter from the lip up to the nose, and then you start injecting your material in a line. As you are withdrawing, try to be more or less lateralized, not in a straight line. And finally, if you still have some let's say wrinkles at the lips, you can do some filling up at this is called the LP8. So you don't start with the smoker's line. You keep the smoker's line till the end in any lip filling. The type of filler that I usually use? Usually we use a thick filler for the blue coded areas. For example, the chin, the jaw, the cheek, and even sometimes parts of the nasolabial fold and Marriott line. I use Voluma. For the rest, the blue coded, I use Volbella. It's really nice, and it stays there for around 4 to 6 months at least. Now, regarding now we will be discussing every part in details. Before that, let's just go over the map of the Botox. We have the Gtox for the glabellar area, we have the orbicularis and the frontal lines. So injection of Botox is usually done at the G2, which is the procerus. G1 is for the G1 and G3 is for the corrugators. The corrugator is a fairly long muscle, and the outer part, the orbicularis, is usually injected at O1, O2, and O3. Usually O1 has the biggest dose, and O2 and O3 are usually half doses. If you need more eyebrow lifting, you might consider a little bit increasing the O3 if you need that lift. How much Botox I usually use? Now, with every dot, I usually put between 4 and 6 units of Botox. At O3 and O2, I usually do half doses, maybe 2 to 3 units will be more than enough for the patient in order to prevent the crow's feet or treat crow's feet. Now, regarding the frontal area, I usually try to spare the outer part of frontalis as much as possible in order to get the beautiful eyebrow lift asked by many patients. And I usually do the F1 and F2. Try always to give, stay between 1 or 2 finger distances between the eyebrow and your injection site, so that you prevent, first of all, ptosis, and you prevent the drooping of the eyebrow. This area should be really spared and not injected by your Botox. So let's go again. This is the rest of the map. Now we talked about the frontal area, we talked about the glabellar area, and now we are going to talk about the nasal area. In the nasal area, we have this is the heart of the procerus. This is what they always talk about. If you inject like 1 or 2 units at this area, it will give you a better and enforced action of Botox on procerus. These are the N4 is for the nasalis. It gives a more slimmer nostril, and this is for the depressor labii nasi. Usually asked by many people, but usually you don't inject it unless you feel that the tip of the nose of the patient is being depressed every time the patient presses his lip. If there is no action, then it's not needed actually, and you don't have to inject that area. These are the injection sites for the gummy smile. Usually gummy smiles can happen due to zygomaticus major and superior levator labii superioris. These are the 2 important sites that are injected. Injection of Botox around the lips, I'm more or less, I always try to tell my patients not to do it unless I feel that filler is not doing well. Then I go and inject a little bit of Botox at this area. The problem of Botox actually around the lip is that it prevents pursing of the lip, and people will start drooling their, anything that they drink, or for example, anything that they drink on their clothes, which is very embarrassing. Mentalis is also very commonly done. Usually this is the C2, and the M3s are the depressor labii, inferioris. These are usually injected in these two areas. Try to be a little bit away from the orbicularis oris, so that they don't have an adverse effect while injecting the area. The jaws, the cheeks, I don't regularly inject the cheeks with Botox, but sometimes I do it in patients with echinacea, patients with seventh nerve palsy, reinnervation after a seventh nerve palsy. If they need to get this beautiful, more symmetrical look, then the cheeks are the area of buccinator is typically injected. Now, for a slimmer face, the Nefertiti face, sometimes we inject the jaw, especially at the masseter area, successively over 1.5 or 2 years, in order to get that slimmer and more, let's say, slimmer look asked by some. So when you are dealing with Botox or filler, our goals is to be less angry, less tired, less saggy. The area should be less saggy. It should be less sad, and you have to be slimmer, more feminine, younger, and more attractive. So we will be now talking about each separately. Now, regarding the fillers that I use, most of them are from Juvederm. I use 3 types of fillers. The core and the most important, the one that lifts the face, is the Voluma. I use also Globella for the tear trough, for the lips, and for the eyebrows. And regarding the, if you need more beautiful face, just refreshing skin care, the Volite is a very nice filler to be used. Belkyra is this is a material that emulsified fats. These are actually bile salts, the oxalic acid. When injecting Belkyra, it's very important to be away from the ramus of the mandible by around 1 or 2 fingers, so that you are away from the muscle. And it's really beautiful, actually. Once done, actually after 2 or 3 sessions, you can see that the double chin really becomes very, very small. Okay, so let's talk about the MD codes if you want to look less tired. So you start, first of all, with, you have to target the eyebrow, you have to target the baggy eyes, the saggy cheeks, and finally you go for the skin quality. So whenever you want, in all the codes, start with the cheeks. Okay, forget about the eyes, so try to, first of all, elevate the mid-face, and this is done by injecting the cheeks, injecting the jaws, and injecting the temples. So once those are elevated, then you start to fill the rest. You go and target the lower eyelids, or let's say the baggy eyes, and then you target the the eyebrow as well. So you start first of all with the cheeks, inject with CK1, CK2, CK3, and then you go and do your tear troughs and eyebrow. How much material do you usually use? I use Voluma around 1 or 2 injections. 2 ml will be fine for each side. And Volbella around 1 ml will be more than enough in the first session. And then in a second session, you can do your Volite, maybe 3 injections. Well, 2 or 3 injections will be fine after a month's time, just to fill up the gaps. So in a list to go for a less saggy appearance, also go and target the cheeks. Okay, as we said, always elevate the cheeks, go with the jaws, and then you elevate the temples by injecting T1, T2, and then you go and fill the areas, the rest of the area, like the nasolabial fold, Marriott lines, and sometimes the chin. A lot of people, they come complaining of a very wide, let's say, upper in the distance between the nose and the upper lip. So in these patients, I really advise you not to go and, for example, increase the volume of the upper lip, because it will really appear like a sausage. It will be really like a sausage structure. I don't advise that. So if you can increase the chin, the distance between the, let's say, lower lip and the chin, rather than decreasing the upper part, this will be much more fruitful for the patient, and it will give an appearance as if the ratio of the upper lip has decreased in size, while we have really targeted the lower chin. So if you do C1 and C6, that would be really much, C1 and C2, it will be much better than, trying to increase the lip size in order to decrease that distance. So as we have said, to elevate the less, to lessen the saggy area, as we have said, you go at CK1, CK2, and CK4, along with the jaw, J1, JW1, and JW2, and then you start filling the area of the Marriott line and the nasolabial fold. And a very important tip is filling the C1 and C2 as well. For a less sad appearance, also you go again and always target the cheeks, the temples. These are the most important cornerstones. And then you can also add your Botox at the glabellar area. This is so important. As we have said, the procerus corrugators being injected. Also try to inject the orbicularis as well. And after a month's time, let the patient come back for skin care with Volite. So for a less sad appearance, some people, they have very beautiful cheeks. They don't have any problem regarding the fullness of the face or the lips, but they come because of this sad face. Sometimes you have to target the baggy eyes. So mostly you have to inject the TT1, TT2, and a very small amount at the TT3 zone. This might really fill up the, let's say, bony structure between the cheek and the lower lid. Also, filling up CK1, CK2, and T1, T2, as we have said, might really help the appearance to improve. So this is the Botox injection, as we have discussed. Um, Now, we are just actually repeating ourselves. This is just a summary for saggy cheeks. You have to go for the cheek zone, deep nasolabial folds, lack of lip structures. Also, we have to go for contouring the lip, as we have discussed, and deep mariottes. Also, we have to do both the chin and the marriott line. We have discussed in details, how to inject the lips, and I think we're almost done. So less tired appearance. Some people have the problem of those patients is that their eyebrows are a little bit down, and they're starting to have some empty zone between the eyelid and the cheek. So filling also the area by filling the cheeks and the temples first, and then you fill up some touch-ups at the tear trough zones, might help them a lot. Was tired. So angry face is usually dealt with by filling the, first of all, relaxing the muscles by Botox, mainly at the glabellar area and the orbicularis. And sometimes filling the lip might help by doing LP1, LP2, LP3, and LP6, as well as addressing the chin. Slimmer face is usually done by, first of all, elevating the face. This is one thing. You have to go at the temples, the cheeks, the jaws. So you start with elevating the face. So at the jaw area, if you just inject J1 and J2, and you have this nice beautiful angle, along with adding deoxycholic acid or Belkyra for the double chin. This will give you a much slimmer face and when needed. I think this concludes my talk. Thank you so much. I hope I was more or less comprehensive dealing with for Botox and filler for it's just an outline.
Doctor, thank you very much. This color coding and this
you're welcome.
Schematic diagram give us a lot of information. I recorded now, put it in the social media. I'm sure you will need help from this diagram when we're doing the filler and the Botox injections. We definitely need these codes, and we need to know how to do them. I personally didn't know these codes really. I'm just doing the Botox only for the facial spasm or hemifacial spasm, but not for cosmetically. But your work is really a piece of an art, and it was amazing.
Thank you so much, Doctor.
Thank you. Let us take questions. I have only one question here from Farhani. How do you reconstitute the vial of Botox?
Okay, so depends on what you are using, whether it's Dysport or Botox. Botox is, I usually put 2.5 cc's of normal saline inside the Botox, and this will help me a lot in calculating my units. And every 0.1 cc is equal to 4 units, which is actually what I need exactly for the site of an injection. So 2.5 cc's per vial per 100 units of Botox will be a good constitute.
I do have a question about the type of the needles.
Yes.
I think the needle of the Botox is just a traditional needle, any 30 gauge or 29 gauge. Or what is the problem here?
I use 32 gauge. I use 32 gauge with a very small shaft. These are really painless and they are very sharp. Patients they don't really feel the injection while you're in.
And when you inject it, the direction of the needle is not directly vertical of the skin, it is just obliquely over the skin to be subcutaneously excised.
Nice. Okay, so whenever you are injecting Botox, you don't have to be deep. This is one thing. Even if you are in the subdermal area, the Botox will go and it will go to the muscle. Now, which is more convenient and safer. Whenever your shaft, or let's say the injection site, should be away from the eye. For example, you never put your needle, for example, in this direction. Okay, so you have to be always away. Your tip of the needle while injecting should be always away, so that diffusion, the matter when it diffuses, it doesn't, for example, affect the lateral rectus, for example, or it doesn't affect the levator palpebrae superioris, causing a droopy lid. I wanted actually just to give you some problems that that you may face. I had a couple of pictures here. So one patient, I injected Botox to him, and after let's say 4 hours, he called me. He had really puffy eyes all over. It was I never had such a problem before, and I found that it was actually an allergic reaction to albumin. Some patients might have allergic reaction to Botox, which is really scary. The problem is that with the allergic reaction, the Botox will diffuse, and it can actually go to somewhere else you didn't want to get treated. طبعا I gave the patient dexamethasone IM intramuscular, and we gave him as well antihistamine and mast cell stabilizers in order to prevent the problem from aggravating.
Yeah. About the ptosis, when you inject in the eyebrow, I'm not sure how you inject in the eyebrow can lead to ptosis, because in ophthalmologists, we know that the upper lid injection, especially the medial side, or sorry, the central side of the upper lid, is the risk factor for the ptosis.
Yes.
But the eyebrow itself, I'm not sure.
Yes, the problem actually is in the technique. I was talking about the shaft, the direction of the shaft when injecting. For example, if look at this lady here. If I inject my needle at this area, if my needle, for example, doesn't go this way, it goes a little bit this way. There will be some diffusion of the Botox to the superior levator palpebrae superioris, and it will cause the droopy lid. Also, injection of any place below the lower eyebrow margin also can cause a droopy lid. طبعا this is very tricky. Why? Some people, they just take off the eyebrow and they just draw a line with a tattoo, or so it can really deceive the person while injecting. So you might really inject in the wrong space, assuming that this is the regular eyebrow of the person.
We question from the complications about the Botox and fillers in the eyelids, their complications.
Complications, we said that, if the Botox went from another space to another, it can do unwanted, let's say, action like a droopy lid, diplopia. Also, injection of Botox at the lower lid can cause diplopia, because in this area we have the inferior oblique. and this will cause the patient to come to your clinic adapting a chin-up position because of the severe diplopia. So in order to decrease that, they just go and do a chin-up position, and it's very, it's really problematic because Botox will need between 2 and 3 weeks in order to, wean its effect.
Okay. A question sharing us about what's the meaning of deep and superficial injections. What is the exact position of the injection? Yeah, it means what is the superficial and what is the deep?
Hello. Actually, I talked about that in the beginning of the lecture.
Yes.
Anything which is coded by blue, you have to be really deep. Anything which is coded by red, you have to be superficial. Now, in deep injections, you have to reach up to the periosteum. I usually use a needle, a 30 gauge needle of around half inch shaft long. Let me just, this picture here. As you can see, this area, any, CK1, CK2, CK4, and JW1, JW2, these are really deep injections.
You mean
Okay.
inside the muscle? Inside.
Yes, you have to go up to the periosteum, and you have to be vertical. Tamam. Here at those areas, along with the lips, you have to be more or less superficial. An exception for the blue ones are the lips. Actually, for example, this side of an injection, you have to be very superficial at the vermilion border. The lips, LP2 and LP6. Other than that, you have to be deep, more or less deep.
I see. We have talked about the type of the needle for the Botox. What about type of needle for the fillers? I think
yes.
The filler, the company which provide us the fillers, they have their own needles, I guess.
Yes. Usually, the Allergan provide you with a needle around 25, 20, 27 or 30 gauge needle in the filler with a half-inch shaft long. Now the cannula, I personally use 38 millimeter cannula of 25 millimeter gauge. 25 millimeter gauge with 38 millimeter cannula, and it's really good quality. It glides very easily and doesn't hurt the tissue. I use the cannula mainly to fill up lips, especially at the level of LP1, and then I can use the needle in order to do the lip contouring. As well as I use the cannula for the tear trough area.
Yeah.
The cheeks and the jaws has to be done with needles. Cannulas doesn't go well. It doesn't go up to the bone.
What about those needles they're talking about? A traumatic needle, which has a blunt head with the opening from the side in order to avoid damage to the vascular structures.
I'm not really. I don't use them in my in my practice. I use those sharp needles. It helps me a lot just going down where I really need to to reach, especially up to the periosteum. Okay. Because other sites I usually use the cannula if I don't really need to go deep.
We have a question is asking about the treatment for ptosis and diplopia. I guess it's a temporary.
Yes, yes, it's temporary. We usually just comfort the patient, and it usually resolves within 2 weeks, 3 weeks time.
The 3 weeks. I thought it's 2 months, but 3 weeks, it's good for us.
Yes, they improve a lot after 2 to 3 weeks.
That's great. That's great. And we don't have any more questions. Something in my mind about the major complications of the filler when you put it in this side here, which is the central retinal artery occlusion.
Yes.
We have faced this problem once in local area. One of the dermatologists who injected filler, and
Yes.
suddenly patient she lost her vision.
Yes.
You know that the exact mechanism still it's not understood well. We don't know how the filler injection into the subcutaneous area can cause or lead to the central occlusion. It's not clear yet.
Yeah, well, this trigon is a very, let's say, dangerous zone because most of the venous return, which comes from the face, it has to go through the eye and then to the back of the back to the cavernous sinus. Okay, it goes directly to your brain. So any increase in the interstitial tissue in this area, this can cause an increase in the venous pressure in the eye, and hence it can cause a central retinal vein occlusion. Okay, so the first thing to do, you know, if you have any vascular problem, you have to use hyaluronase in order to get rid of the filler as soon as possible. So if the patient really complains, they have a problem, you go and try to remove that filler. The hyaluronase should work within 2 or 3 hours. It's almost instantaneous. It will relieve the pressure done by the filler. Also, it will be very helpful to take for some anticoagulants like aspirin or ADP inhibitors.
This
Those
hyaluronase
new.
you talked about, is it an injection to the site of the previous injection, or it's intravenously given to the patient, or how it is?
There are actually two mechanisms. One of them is an increase in the interstitial pressure, which will cause an impedance of the venous drainage, or an increase in the pressure of the veins. And the other one is a direct injection in the supraorbital artery, which will cause a reverse bolus to the central retinal artery, causing its closure.
No, I mean the hyaluronase when you give it. It's
yes.
Intravenously to the patient or to the site?
No, sir, no. Hyaluronase should be given at the site of an injection, of the filler injection.
All right.
So the thing about that is that you need to relieve the interstitial pressure. In order to do that, you have to get rid of the previously injected filler. And it works. Within 2 hours, 3 hours, things really improve.
If you kindly show us that dangerous area of the filler to avoid us in this picture with your mouse, please, for the audience to be aware of it.
Thank you. Okay, so it's mainly the glabellar zone. Try to avoid this area. Don't use a lot of filler. And if you are obliged to do that, you have to be very, very, very superficial. This is one thing. And whenever you are injecting, please try to make sure you are not in an artery, not in a vein, by sucking your plunger backwards and check that there's no blood coming out.
Oh, okay. Thank you very much.
Yeah.
There's a question. She's asking about, do you recommend use of Botox in the middle part of the eyelid for dry eyes?
You're talking about injection of the
middle part of the eye.
You're talking injection of the lacrimal gland. Is this the question?
I'm not sure. This is
okay. So injection of the lacrimal gland, obviously there is no benefit of doing it unless you have an excessive lacrimation. It's not dryness; it's excessive lacrimation. Sometimes we inject this area, but I really don't recommend, because this might cause also a droopy lid. One of the side effects, for sure, it will cause a droopy lid along with the with injection of the lacrimal gland.
All right, Dr. Khalil, we don't have any more questions right now. It was an amazing deductive course for us.
Shukran. Thank you so much. Thanks for your time.
So much from you. Thank you very much. And
thank you,
all the attendants who hope you enjoyed us.
Thank you.
Stay safe, and see you another time, another event. Thank you, Dr. Khalil. See you again. Good.
Thank you. I thank the audience. Thank you so much. Thanks for your patience.
Goodbye.
Bye-bye.